我们紧接着最后把 Dr. Zach McCormick 的简报结束，那我们再开始做我们的 Q&A。
Good afternoon, everyone.
那大家辛苦的一天就结束了，所以我们是最后一堂了，那我们就开始。
Good afternoon, everyone. I hope the rest of the day has gone really well, and we'll jump into the second part of this talk on discovertible pain. So in this portion, I'll talk about treatment of discovertible pain. So still the same disclosures as I had this morning. I do have research grants with Boston Scientific and Relievant. This is the company that manufactures equipment used for basic vertebral nerve ablation. But I will otherwise keep this brand agnostic. So we'll talk a bit about intradiscal injectables, both regenerative agents and then steroid, corticosteroid. Where if you take a look at the literature, agents that have been tried, and steroid, corticosteroid, used for basic vertebral nerve ablation, vertebral pain. So still the same disclosures as I had this morning. I do have research grants with Boston Scientific and Relievant. This is the company that manufactures equipment used for basic vertebral nerve ablation. But I will otherwise keep this brand agnostic. So we'll talk a bit about intradiscal injectables, both regenerative agents and then steroid, corticosteroid, and then we'll touch on basic vertebral nerve ablation as well. So first, intradiscal therapies. There are numerous. There are all sorts of agents that have been tried, injected into the disc as a presumptive therapeutic agent. None has really shown super robust outcomes. If it had, we'd all be using it. But within categories, there are certainly orthobiologics, and some are autologous, some are not. There are numerous clinical trials ongoing right now with various intradiscal agents. What I'm going to focus on is one of the common regenerative agents, so-called regenerative, and that being platelet-rich plasma, which I think that you all are fairly familiar with. There are certainly others, bone marrow aspirate, mesenchymal stem cells, amniotic fluid that is used by some, and then also adipose-derived stem cells. Anyway, in the interest of time, I'm going to focus primarily on platelet-rich plasma, where if you take a look at the literature, the data is probably best for patients with discogenic back pain in supporting platelet-rich plasma. We shall see what science brings us next. Yes, there is some data on BMAC, bone marrow aspirate. I'm going to focus this, though, on platelet-rich plasma. So I think this is very familiar to all. We're doing a blood draw, centrifuging the whole blood in order to separate the platelet-rich layer that can be then extracted, and a second spin can be performed. Some machines are able to do that all without actually touching anything or manually removing and extracting the platelet-rich layer. But at the end of the day, we're looking to concentrate that portion of the whole blood. For a disc, like we talked about previously with provocation discography, I typically try to have 3 milliliters available. More than 3 milliliters is more than one needs. We don't want to overpressurize the discs, as we talked about earlier today in the former lecture. And I typically mix PRP with an antibiotic, and this is an area of debate, whether or not one needs to put antibiotic in their milieu of a therapeutic injectate. I, being conservative, want to make sure I prevent infection. And we will talk a little bit more about indolent infections as well. So I do tend to put Ancef or Cefazolin in. I have gone back and forth on reconstituting it with water or saline versus an anesthetic, but usually I will reconstitute the ANSAT for cefazolin with ropivacaine, and ropivacaine mainly because it is the least chondrotoxic of local anesthetics, but you don't need to put an anesthetic in, and some people would argue that it's probably best not to put an anesthetic in. And instead, if you're going to use an antibiotic, it can be mixed with sterile water or saline. If you're not going to use intradiscal, I would recommend at least using IV antibiotics, again, to prevent discitis. So there's a small but unavoidable risk of discitis anytime you're entering the needle, entering the disc with a needle. And the goal here would be to provide coverage of skin flora. So if it's not cefazolin, then vancomycin or potentially clindamycin are also reasonable choices. So the big, from a technical standpoint of completing this procedure, most would not be using a manometer. I don't, mainly because of volume issues and injecting through all the tubing. But the idea is, at least by tactile feel, you don't want to be pressurizing the disc and the annulus. So in the lumbar spine, this is usually between 1.5 to 2.5 mils in my experience of intradiscal injectate. What is the goal constitution of the PRP? So again, there is some debate here. So some will say that you want to create an anti-inflammatory milieu, and so that would be a leukocyte or PRP, with the idea being that we're trying to reduce inflammation. If there are modic changes, for example, type 1 or type 2, ideally we're going to be trying to skew the disc environment such that we're reducing inflammation and edema. The counterexample to this, or I guess the counter-argument, is that there may be indolent infection in some of these discs, particularly if we see type 1 modic changes, and we'll touch on that a little bit later on in this talk. If that's the case, and we believe that some of these discovertebral complexes have indolent infection, perhaps some have argued that you actually do want leukocytes in the PRP, that you're essentially going to enhance the ability to fight that infection, or directly any bacteria that are there living in that end plate disc complex. I personally have been using leukocyte pore with the idea that we're trying to reduce inflammation in that area. But to be truthful, no one really carefully studied this. There certainly has not been a head-to-head clinical trial where patients were randomized to a leukocyte-rich versus leukocyte poor preparation for discogenic type back pain. But I will say that there is a fair amount of data on ideal concentrations. So we can go by concentration, and many would recommend a 4 to 7x concentration relative to whole blood. The other way to look at this is the total number of platelets, and there are other studies that say there's kind of a threshold, and once you get beyond a certain threshold of total number of platelets, that's going to really promote healing. And some have advocated for 1.5 million per milliliter injected. Other issues with regard to the constitution of the PRP milieu itself is that ideally you remove red blood cells as much as possible. Some have recommended trying to keep to less than 1%, but the idea here is that the red blood cells are chondrotoxic, and the endpoint is it's cartilage. So ideally we don't want to be doing damage to that, and reducing the red blood cell content is important for that purpose. So one other piece on PRP injections of the disc, there isn't evidence on this. I'm not aware that anyone has instituted a specific rehab paradigm or physical therapy protocol post-PRP disc injection, but logically this makes sense to me, and so this is what I recommend for our patients for whom we do intradiscal PRP injections, and essentially that we put them in an extension style physical therapy program where we're really unloading the anterior column in the disc, and kind of giving that area a chance to rest. Obviously, steroid injections compared to so-called regenerative injections or PRP injections, two different paradigms. And if we are hoping to achieve some element of healing, whether it's to annular fibers or to the defects in the vertebral body end plate, logically, even if there's no hard data behind this, it makes sense to me to allow that area to rest. And so we put these patients into a relative extension program. Okay, so on to intradiscal steroid. We have been using these, and the history here is that when the basivertebral nerve ablation procedure came about in the United States, there were very few insurance companies that were covering the service, and we would often have to go through a long process of submitting the requests for the service. It would get denied, we'd have to appeal it, denied, appeal, and back and forth. And often it could take, anywhere between 3 and 6 months to get the procedure authorized. And in the meantime, these patients are in pain. And so we started doing intradiscal steroid injections with the idea that if there's an inflammatory component to vetebrogenic pain, particularly in the context of a type 1 motive change, logically it makes sense that a steroid should help for at least a temporary period. And we would use this as a way of bridging the gap from the time the patient presented to us and we ordered the basivertebral nerve ablation procedure and the time they actually could have it after, hopefully, we were able to work with insurance to get it approved. So in the meantime, we did do a systematic review and actually took a look at the literature. And to condense this, just to one slide, essentially we found low quality evidence that intradiscal steroid injection does cause or does provide short-term pain reduction and improvement in disability in people specifically with modic type 1 or type 2 changes. It's low quality because there aren't a large number of randomized controlled trials. So it doesn't mean that it doesn't work, it just means that if there are more studies, it could change the level of evidence, but we did find evidence that this statement is true. Alternatively, we also found that intradiscal steroid injection does not necessarily is not associated with pain reduction, improvement in disability if patients are only selected by provocation discography, and that makes some sense. So if you imagine that provocation discography is probably selecting a group of patients who have annular dominant pain, especially if it's done at low pressure like we talked about earlier, that's probably less likely to respond to steroid because it's less of an inflammatory condition. Whereas if someone has a type 1 motor change at the end plate, that is indicative of inflammation. So in theory, logically, a steroid should provide benefit, though probably not durably so. So we did find in this review that it is generally not the case that these injections are gonna help for more than 6 months. And I can say anecdotally, most patients in my experience for whom we do an intradiscal steroid injection get 3 to 6 months of benefit. I've seen them last for a year, but I think the usual range that I've observed is about 3 to 6 months of benefit. So, so interestingly, that type 1 motive change, we alluded to this, but is it aseptic inflammation, or is it possible that there's infection going on? And there is quite a bit of writing on this in the literature. Classically, it was thought that P. acnes, the bacteria, anaerobic bacteria P. acnes, can infect the end plate and the disc, and that can be an indolent infection. It can be a low-level, just simmering infection that isn't causing full-blown discitis, but it is driving pathology and contributing to the pain syndrome in a subset of folks that have especially type 1 modic change and chronic axial low back pain. More recently, it looks like it's not just P. acnes, that there are other anaerobes that do the same thing. But the point here is that some subset of patients with type 1 modic change, there may be an infection that's going on and contributing to the pain syndrome. So there's been a little bit of work on identifying who's more likely to have infection. So we look at folks with type 1 motor changes and analyze demographic factors. Turns out that young men who have type 1 motor changes are, you know, by statistics anyway, more likely to have an indolent infection in their disc and/or end plate. So something to consider. And again, I would advocate for considering adding antibiotic to your intradiscal injections, whether it's with PRP or a regenerative agent, a purported regenerative agent, or certainly I always use it with when I inject steroid into the disc, and that's true of all the physicians in our practice at the University of Utah. So we probably can treat that infection by putting an antibiotic into the disc if we're going to put another substance in there anyway for therapeutic purposes. So that leads us now to basivertebral nerve ablation, and certainly I'm acknowledging there are many other possible intradiscal injectables, more than we have time to cover, but you know, it's still an evolving science and area that we have not mastered as a medical community yet. But this is an interesting area. So basivertebral nerve ablation is much newer. People have not been targeting this nerve for very long, but it has gained significant interest. So this, just to orient you, I mean, this is a pedicle access procedure. So a Jamshidi style needle, similar to what we use for kyphoplasty or vertebral augmentation, is advanced through the pedicle, stylet is removed, and then a channeling tool is used to create a bone channel to the midline of the vertebral body along its equator. So midline and AP along its equator in the lateral view, where we know the stem of the basivertebral nerve lives. And this is a bipolar electrode, and so that's then used to create a heat lesion. And you're seeing what that looks like on MRI some number of weeks later, where the nerve is possibly actually transected with the channeling tool, and if not, it's certainly coagulated using that bipolar electrode. And this is again what those lesions would look like on MRI if you did MRI 4 to 6 weeks later. Here you're seeing something similar, so what the lesions look like on MRI 6 weeks later and then 6 months later. Of note, I would say that this is probably too anterior. You can actually see the basivertebral foramen right here. Ideally, this lesion would have been placed a bit more posterior in the vertebral body, where the stem of the basivertebral nerve lives. This one might have missed just slightly. Same idea actually with the S1. There's S1 body here. This lesion is probably a little bit too anterior. Ideally, it would be more posterior, but the purpose of this is to show you what the lesions look like on MRI. These are not my images, but they came from a paper. So we've also looked at this data. This is a systematic review from our group where we took a look at all the literature, coalesced it, and then provided some pooled analyses on success rates. And so in the forest plot here, you're seeing it at 6 months and at 12 months, when we consider responder to be at least 50% reduction in pain, what the proportion of responders was that was reported across studies, and this diamond is showing you the pooled responder rate. So it lives somewhere around 70%, probably 65 to 70%, and that's fairly durable out to 12 months. This comes from one study, and there's actually reinforcing data that's been published, subsequently published after the systematic review. But if you look at the proportion of responders, again, considering responders at least 50% pain reduction in low back pain, this study showed that responses were durable out to 5 years, which is really interesting. Obviously, we don't have a lot of treatments for low back pain that last for 5 years, so this is interesting and unique. And the theory, anyway, is that the basivertebral nerve is not myelinated, and because it is not myelinated, there's no scaffold for healing and regrowth, reconstitution of the basivertebral nerve the way there is with, for example, medial branch nerve or other peripheral nerves that are myelinated and that we know tend to regrow, anywhere between 6 to 24 months later. So, for example, the median duration of effective medial branch ablation is 11 months, at least from the SMOOC study. So we're seeing longer benefit with basivertebral nerve ablation. And then just similar data here, we're seeing in this case responders as defined by Oswestry Disability Index improvement of at least 15 points. And You're again seeing the pooled data here, the pooled responder rate at about 75% at 6 months, and the same at 12 months. And then similar trend here where there's durability to that outcome even out to 60 months or 5 years. This is a more recent paper. We took a look at, we combined 3 different clinical trial data, the data from 3 clinical trials, and looked at long-term outcomes as they relate to healthcare utilization. So across these 3 clinical studies, the latest follow-up was at 5.3 years, and we looked at various treatments that individuals were receiving at baseline and 6 months before baseline, and then followed them out after the index basivertebral ablation procedure. And what you're seeing here, these are survival plots, where we're seeing the time to an intervention, for low back pain, a treatment intervention. So at time 0, this is when the individual had their basivertebral ablation procedure, and then you can see the odds of having no intervention. When we count it as any kind of lumbosacral ejection, an RFA treatment of the either sacroiliac joints or the set joints, or surgery, even out to 8 years, probably about 70% of patients didn't need any of those therapies. And you can see it broken down by subtypes of different low back pain treatments. This one being spine surgery. So very few patients were needing to undergo spine surgery following basivertebral ablation, at least in this cohort of 3 combined clinical trial cohorts. Interestingly also, we saw pretty significant reduction or cessation of opioids. So of the patients who started out on opioids, nearly 2/3 of them were no longer needing opioids for their low back pain at that mean 5.3-year follow-up. We have a bit of real-world data, so we're still collecting this, but we have a registry of a prospective cohort data that we're collecting out to 2 years in real-world patients, so not carefully selected clinical trial patients, but folks that we see in everyday practice who potentially have more comorbidities, possibly multifactorial back pain, et cetera. And we're collecting this data. So this is some interim data. We have more than this. We have 57 patients enrolled, and we'll soon have 1-year data on those 57. But this is what I have right now. So the first 33, we categorize them as 26 of them had primary vetebrogenic pain, 7 had fairly strong other sources of pain, including stenosis with claudication, spondylolisthesis, SI joint pain. Within the group with primary vetebrogenic pain, 10 of them would have qualified for the clinical trials that have been done. So 10 of them had, let's call it, highly dominant vetebrogenic pain without other sources. And this is our data across the entire cohort. So at 2 years in this cohort, we're seeing mean changes in ODI of about 15. So that's certainly on the upper end of what's considered clinically significant. And then a mean change of 3 on the visual analog scale. So certainly above the minimally clinically important change of 2 for low back pain patients. And then if we look at this by responders, at 3 months, 1 year, and 2 years, this is what you see across the entire cohort. So folks that had dominant vetebrogenic pain and folks that had, potentially mixed sources of pain and even maybe dominant sources of other pain, but some component of vetebrogenic pain. So kind of a messier population, but a real world population. And this is what our data showed. So our responder rates drop relative to the clinical trials, which you'd expect in a more real world challenging population. But even at 2 years, we're seeing over 50% of patients are still reporting at least 50% reduction in pain, or at least a 12-point improvement in the ODI. If we hone in and we look at the patients that from this real-world cohort, but who had less multifactorial pain, would have actually qualified for the clinical trial had it been enrolling. still. We do see now responder rates that are closer to what the clinical trial data looks like, where at 2 years, 60% of patients reported at least a 12-point improvement in ODI, 80% reporting at least 50% pain reduction. So again, maybe not surprising, if they have less complicated pain, and the dominant source is the vertebral end plate, outcomes look better. So just in conclusion,